Welcome to the Deep Dive. We're here to condense hours of complex technical information into the essential knowledge you need right now,
Exactly.
especially if you're an endoscopy technician, a nurse, maybe a trainee. You know the endoscopy suite? It's not just a room, is it? It's like this precisely organized theater filled with micro tools.
That's a great way to put it. And understanding these tools isn't just about knowing how to load them.
No.
It's about anticipating the pathology, understanding the why.
So for this deep dive, we're drawing from Dr. Raju's video series, Endoscopy Technology Theory Accessories. Right.
That's the source. It's fantastic material that really emphasizes why you need to grasp the function behind every single instrument you pick up in GI endoscopy.
Okay, so our mission today is clarity. We want to categorize, analyze this, well, pretty extensive list of accessories.
Focusing on the specific applications.
Right, whether that's for visualization, diagnosis, critical hemostasis, or maybe those more complex therapeutic procedures. So let's start at the beginning. Tools that just help with the initial look around, the basic diagnosis.
Sounds good. Let's begin with something that seems simple but has huge benefits.
Right.
The cap, or distal attachment. You just secure it to the end of the scope.
And straight away, it does two key things.
Two crucial things. Use number one is all about visualization and stability.
Okay.
So if the endoscopist is in a tricky spot, like high up in the cardia or navigating that sharp angle in the duodenal bulb,
Yeah, those can be tough.
the cap helps stabilize the scope tip, lets them get a really sharp, detailed look at a lesion.
Makes sense.
Uh-huh.
And the second use, you mentioned life-saving.
Yes, tamponade. In an acute bleed,
Yeah.
sudden bleeding,
Right.
the cap can be gently pushed right against the bleeding site, applies temporary pressure.
So it buys you time.
Exactly. Buys you, the technician, those vital seconds to get the injection needle ready, or maybe a hemostatic clip.
Got it. Okay, so the area is stable. We can see clearly. Let's talk about the spray catheter. This is about applying dyes, right? Painting the inside to find problems.
Precisely. It's like using contrast to make things stand out. And the key here is knowing which dye to use for what potential issue.
So it's specific.
Very specific. If the doctor's screening the esophagus looking for squamous cell cancer, you'll be reaching for Lugol's iodine. It stains normal tissue brown, but abnormal areas don't take up the stain, they stand out.
Okay. Lugol's for esophagus. What else?
Then you have acetic acid. This one's pretty versatile.
How so?
Well, it helps screen for Barrett's esophagus and any associated dysplasia. Also good for checking gastric intestinal metaplasia in the stomach. And really importantly, it helps define the true edges of difficult serrated polyps. Those can be really subtle.
Right, I've heard those are hard to see sometimes.
They are. Acetic acid makes the surface patterns clearer. Then finally, we have indigo carmine or methylene blue.
Okay.
You'll see these used a lot in the duodenum and the colon. The reason is they help spot polyps in patients who have inherited conditions like FAP, MAP, or Lynch syndrome.
The high-risk groups.
Exactly. And they're also standard for screening for cancer or precancerous changes in people with longstanding IBD, that's ulcerative colitis or Crohn's disease, usually for 10 years or more. Helps highlight subtle changes in the mucosa.
So visualization's covered, dyes are applied. Next step is often getting tissue samples. Let's talk cytology brush. I hear there's a key difference in types depending on the procedure.
Absolutely. Two main types. There's the regular brush, goes through a standard EGD scope, simple.
Okay.
Then there's a specialized one that needs a guide wire. That's specifically for ERCP procedures for brushing inside the bile duct.
Gotcha. And what are we using them for generally?
Common use is checking for esophageal candida, that, white stuff, fungal growth.
Right.
But it's also a really important add-on to biopsies when you're checking for infection or cancer. Especially useful in strictures, those narrowed areas, particularly in the bile duct where getting a good biopsy can be tricky. The brush scrapes cells off.
Okay, makes sense. And speaking of biopsies, let's get into biopsy forceps. The obvious use is, well, taking a biopsy when you see something suspicious, maybe cancer, inflammation, infection.
That's the primary use, yes.
But the source material highlights something I found surprising, using them when the area looks totally normal.
Yes, and this is a critical point for technicians to understand for preparation. Why biopsy normal-looking tissue? It seems counterintuitive.
It does.
But there are specific situations. The source points out 4 key ones. First, a young person, difficulty swallowing. You biopsy the normal-looking esophagus. You're checking for eosinophilic esophagitis, or EOE.
Okay, EOE.
Second, abdominal pain, maybe suspecting H. pylori. The stomach might look fine on camera.
But you still biopsy.
You absolutely take biopsies. H. pylori can be there without obvious inflammation sometimes. Third, think celiac disease.
Yeah.
Loose stools, maybe iron deficiency anemia. The duodenum might look perfectly normal.
Biopsy anyway.
Biopsy anyway. Standard protocol. And fourth, an older patient with persistent loose stools. You biopsy the colon, even if it looks normal, checking for microscopic colitis. You just can't see it without the microscope.
That's fascinating. It really highlights the why behind just handing over the forceps.
Exactly. And don't forget the different types of forceps you need ready. There's the standard cup.
Right.
The jumbo cup, bigger bite, can even sometimes remove tiny polyps, less than 3 millimeter. Then there's a spike version.
What's the spike for?
It helps anchor the forceps, especially on slippery mucosa, lets you take multiple biopsies from the same area without the tissue pulling away. And finally, hot biopsy forceps.
Uses current.
Yes, uses electrocautery. Good for slightly larger or flatter polyps that might bleed a bit when you just pull them off. The heat helps cauterize as you remove it.
Okay, so we've surveyed, we've sampled. Now let's move into fixing things. Therapeutic accessories, starting with the injection needle. This seems crucial for active bleeding. What does the tech need to know? Is it always epinephrine?
Good question. No, it's definitely not always epinephrine. And that's the challenge for the tech, knowing the likely pathology guides what you prepare.
Okay, so when is it epinephrine?
If it's bleeding from an artery or arterial thing or ulcer bleeding, a Mallory-Weiss tear, a Dieulafoy lesion, bleeding after a polypectomy, even some diverticular bleeding, in those cases, yes, epinephrine, it causes vasoconstriction, clamps down the vessels.
Stops the flow. But what if it's not an artery, like veins, varices?
Exactly. If the bleeding is from varices esophageal, gastric, fundlin, the injectate changes completely.
What do we use then?
You're using sclerosants, things like STS sodium tetradecyl sulfate or sometimes specialized glues. These work differently. They irritate the vein lining, causing inflammation and clotting to seal it off.
Wow, okay. Same needle, different job.
And that's not all. That same simple needle is used to inject saline, often mixed with a dye like methylene blue or indigo carmine.
Why would you do that?
Submucosal injection. You inject it underneath a polyp. It lifts the polyp up, creates this fluid cushion between the polyp and the deeper muscle layer.
Making it safer to cut off the polyp.
Precisely. Aids safer section, especially for larger or flatter polyps. And think about other uses too, tattooing. Injecting a tiny spot of ink to mark an area for future follow-up or for a surgeon.
Right, localization.
And even injecting botulinum toxin Botox into muscles, like in the esophagus for achalasia to relieve spasms. It's an incredibly versatile tool.
It really is. Okay, next up, the band ligature or bander. Primarily for varices, right? Especially esophageal.
That's its main job, yes.
Yeah.
Treating variceal bleeding, particularly in the esophagus, sometimes gastric varices near the cardia, too. It deploys little rubber bands to strangle the varix.
But it's used for other bleeds, too.
Oh, yes. Increasingly versatile, it can control bleeding from hemorrhoids. It's also used for some arterial bleeds, Mallory-Weiss tears, Dieulafoy lesions, post-polypectomy bleeding, diverticular bleeding, and even for diffuse capillary bleeding, like in watermelon stomach or AVMs.
And it has a role in removing tissue, too, like EMR.
Absolutely. This is where it gets quite advanced. For endoscopic mucosal resection, or EMR, you can use the bander to suck up the target tissue, maybe Barrett's esophagus, early cancer, create a pseudopolyp, band it, and then snare it off above the band.
So it helps lift the tissue for safer cutting.
Exactly. Also used effectively for removing certain carcinoid tumors, especially in the rectum.
Before we move to energy devices, you mentioned a specific tool for really bad variceal bleeding.
Oh, right. The Seng-Staken-Blakemore tube. This is really a stabilization tool for catastrophic variceal bleeding when the usual endoscopic methods, the banding or injection, just aren't working or can't be done quickly enough.
How does it work?
It's a tube with 2 large inflatable balloons. One sits in the stomach, the gastric balloon. You inflate that first to anchor it, then you inflate the second, longer esophageal balloon.
And that puts pressure directly on the bleeding esophageal varices.
Massive pressure. It's a temporary, life-saving bridge to buy time for more definitive treatment or transfer. Requires careful monitoring, though.
Okay, a critical tool for emergencies. Now let's talk energy. The electrosurgical probes. Multipolar, heater, and APC. They all use heat or current, but how do you choose?
Good question. There are practical differences. The multipolar probe is probably the workhorse for many types of bleeding. You typically use it after injecting epinephrine to slow the bleeding down a bit.
Right.
It uses electrical current between multiple electrodes at the tip to directly cauterize the vessel. Great for ulcers, MWS, Dieulafoy, post-polypectomy sites.
And the heater probe?
Similar applications controls the same types of bleeding, but its mechanism is different. It uses an internal heating element to heat the tip and then applies direct thermal coagulation through contact. No current passes through the patient.
So just heat. Any advantage?
Some prefer it for certain situations, maybe needing deeper, sustained heat application. It's another option in the toolbox.
Then there's APC argon plasma coagulation. That sounds different. Uses gas.
Totally different approach. It uses argon gas, which is inert, and passes electrosurgical current through the ionized gas stream. It creates a plasma beam.
And it doesn't touch the tissue.
Exactly, it's non-contact coagulation. This makes it excellent for treating larger surface areas of bleeding, like vascular ectasias or diffuse oozing from ulcers.
What else is it good for?
Because it's non-contact and covers broad areas, it's the go-to for ablating tissue. That means destroying unwanted tissue layers, think residual polyp tissue after removal, treating Barrett's esophagus, even debulking parts of a tumor to relieve obstruction.
Wow, okay. Ablation.
And it's also really useful for dealing with stents. You can use it to clear out tissue ingrowth that's blocking a metal stent, or even sometimes to help cut or trim a stent that's migrated. Comes in different forms too: aerial, side fire, circumferential beams for different jobs.
Very versatile.
Yeah.
Okay, let's shift to closing things up, sealing defects and getting things out. First, hemostatic spray or hemospray.
Right, hemospray. Think of this as a temporary fix for widespread bleeding. It's a powder you spray onto the bleeding area.
How does it work?
It absorbs water, concentrates clotting factors, and forms a kind of mechanical barrier. It's especially useful when the bleeding is too diffuse or too brisk for standard contact methods like clips or probes, or maybe the location is just too awkward. It buys time.
A temporal safety net. Good phrase. Then, the standard clips through the scope clips, or TTS clips. These seem ubiquitous.
They are. And for technicians, you basically need these ready for almost any procedure because they do so much. 3 main functions.
Okay, first.
Hemostasis. Obvious one. Clipping bleeding ulcers, Mallory-Weiss tears, Dieulafoy lesions, diverticular bleeds, post-polypectomy bleeding sites, just closing the vessel mechanically.
Makes sense. Second.
Closure. Closing holes. If there's a defect left after removing a large piece of tissue with EMR or ESD, you clip it shut. Or, crucially, if there's an accidental perforation, clips are the first line of defense to try and close it endoscopically.
Life-saving closure. And the third function, you said it was complex.
Anchoring and marking. You can use clips to anchor feeding tubes in place or to prevent stents from migrating. They're vital for marking tumor sites for radiation oncology.
So the beam can be targeted precisely.
Exactly. Or even for interventional radiology to guide coiling or glue placement. And a clever trick during difficult ERCPs, sometimes a fold of tissue is in the way of the bile duct opening. You can actually place a clip on the fold and use it to gently pull the fold aside.
That's quite inventive. Okay. Moving beyond TTS clips, there are bigger closure devices.
Yes, the over-the-scope clip, or OTS clip. Think of it like a large bear trap deployed over the scope tip.
Wow, what's it for?
Bigger problems. Massive bleeding that TTS clips can't handle, closing larger perforations, treating fistula's abnormal connections, like maybe a gastrostomy site that didn't heal properly, and also for anchoring stents sometimes. It provides much stronger closure.
An even more robust closure. Suturing.
Now you're talking about the endoscopic suturing device. This is a major advance, bringing near-surgical closure capabilities through the scope.
What are the main uses?
Anchoring stents very securely to prevent migration, performing gastric reduction procedures endoscopically, a big deal for bariatric patients or alternatives to surgery, and closing complex perforations or fistulas that even OTS clips might struggle with.
Amazing technology shift. Let's move to cutting tool snares. Cold snare first.
Cold snare. Simple. No electricity involved. It's basically a wire loop you close around a polyp and cut it off mechanically.
Where do you use it?
Standard for removing smaller polyps in the colon, typically in the 4 to 10 millimeter range, especially non-pedunculated flatter ones. The idea is less thermal injury means potentially lower risk of delayed bleeding compared to using current.
Okay. And the hot snare.
Hot snare uses electrosurgery. You loop the polyp, apply current as you close the snare. The heat cuts and cauterizes simultaneously.
For bigger polyps.
Yes, generally for polyps larger than 10 millimeters or for pedunculated polyps, ones on stalks. Also essential for EMR techniques we discussed earlier, often used after lifting the tissue with injection or banding. And snares, both hot and cold sometimes, are great for grabbing and retrieving foreign bodies or dislodged stents.
What about really big polyps with thick stalks? High bleeding risk.
Ah, that's where the ligating loop comes in, sometimes called an endoloop. It's a pre-tied loop on a catheter.
How does it help?
You deploy it around the thick stalk of a large polyp before you cut it with a snare. You tighten the loop, strangulating the blood vessels in the stalk.
Like tying it off first.
Exactly. Dramatically reduces the risk of major bleeding when you then cut the polyp off. You can also
Yeah.
sometimes use it after cutting if there's bleeding, or even as an emergency tool to try and close a defect or perforation.
Okay, makes sense. Now, getting things out, retrieval tools, the net.
Retrieval net, exactly what it sounds like. A net on a catheter used to grasp and pull out large polyp specimens, or maybe multiple smaller polyps at once. Also essential for removing foreign bodies, like a large piece of impacted food. The classic steakhouse syndrome.
Got it. What about the trap?
The retrieval trap, or specimen trap. This is simpler but vital. It's a little container that connects into the suction line near the scope.
Why?
When small polyps are removed, sometimes they just get suctioned up through the scope channel. The trap catches them before they disappear into the suction canister, so they can be sent to pathology. Very important not to lose those specimens.
Absolutely. And the retrieval hood. Sounds protective.
It is key safety device. It's a soft plastic hood fitted onto the end of the scope. You use it specifically for retrieving sharp foreign objects. Think pins, needles, razor blades, safety pins.
Things you definitely don't want scraping the esophagus on the way out.
Precisely. You grasp the sharp object with forceps through the scope, then retract it into the hood. The hood then inverts or covers the object as you withdraw the entire scope, shielding the esophagus and throat from injury.
Clever design. Any other retrieval methods?
Yes, overtubes can be used. A large tube placed over the endoscope can help retrieve larger foreign bodies or facilitate multiple scope insertions. And rat tooth forceps, strong grasping forceps, also used for foreign bodies and sometimes removing stents.
Okay, nearly there.
Okay,
Let's wrap up with tubes, dilation, and stents. Feeding tubes first.
quick overview. Nasogastric tube, NG tube, short-term feeding, common on hospital wards, goes through the nose to the stomach.
Right.
Jejunal tube, J-tube, also usually short-term, placed endoscopically over a wire past the stomach into the jejunum, used when the stomach isn't emptying properly.
Okay. And long term?
That's the PEG tube percutaneous endoscopic gastrostomy, or G-tube, placed endoscopically through the abdominal wall directly into the stomach for long-term feeding.
And you mentioned another use.
Yes, critically remember it can also be used for venting. If a patient has an obstruction, maybe from a tumor, and they're vomiting constantly, a PEG can be placed just to drain the stomach contents and provide relief, even if they're not being fed through it.
Good point. Dilation next. Widening narrowed areas.
Two main methods, balloon dilators. These are catheters with inflatable balloons of various sizes.
Where are they used?
Highly versatile, used for strictures pretty much anywhere. Esophagus, pylorus, stomach outlet, colon, connections after surgery, anastomoses, and also in the bile duct and pancreatic duct during ERCP.
And the other method?
Bougie dilators. These are more rigid, tapered dilators of increasing sizes. You pass them typically over a guide wire down the esophagus.
Primarily esophagus.
Typically, yes. Mostly used for straightforward esophageal strictures. Less flexible than balloons for navigating angulated areas.
Okay. Finally, stents. Metal or plastic tubes. Main use is obvious. Relieving obstruction, right?
That's the primary driver, yes. Relieving malignant obstruction cancer, blocking the esophagus, stomach outlet, colon, or bile ducts, restoring passage for food or fluids.
But they do more.
Much more. They can be used to bridge leaks, maybe after surgery, anastomotic leaks, or to seal perforations that haven't closed with clips. They're essential for draining fluid collections, like pancreatic pseudocysts, by stenting internally between the collection and the stomach or duodenum.
And facilitating procedures.
Yes, that's a newer application. Sometimes in patients with altered anatomy after surgery, like gastric bypass, getting to the bile duct for ERCP is really hard. They might place a special stent, a lumen-opposing metal stent or LAMS, to create a temporary tunnel, say from the stomach pouch to the excluded stomach, allowing the scope to pass through to do the ERCP. Or creating a gastrojejunostomy endoscopically.
Incredible range of applications.
Right.
Well, that was an incredibly thorough deep dive. We've gone from, well, the the simple diagnostic cap, all the way through to these complex suturing devices and multifaceted
It
stents.
really covers the spectrum.
And it absolutely underscores how crucial your role is. Whether you're the technician, the nurse, the trainee, your knowledge of the potential pathology and having the right tool ready is just paramount.
It truly is. And this knowledge, this foundation, it absolutely has to be paired with an awareness of safety and risk.
That's a critical point.
Dr. Rogers' material really emphasizes this. If these instruments aren't fully understood, if they're not used correctly, especially things like the energy devices, the dilators, the snares, they carry real potential for serious harm.
Like what?
Trauma, uncontrolled bleeding, perforation. Understanding the potential pitfalls is just non-negotiable. Safety first, always.
Absolutely. So as you're there, organizing that vast array of specialized equipment before the next procedure, we want to leave you with a final thought, something to mull over, connecting back to the versatility we've discussed. Given that so many of these tools, the clips, the snares, the injection needles, have multiple therapeutic uses, sometimes life-saving ones, if you had to pick just one accessory from everything we've covered, which single tool do you think offers the greatest overall versatility for potentially saving a life in the endoscopy suite?